Welcome to the Hospital Medicine Unplugged podcast.
It's great to be here. Today, we're diving into, well, one of the most common findings we see, right? Hematuria.
Absolutely. And common doesn't mean simple. It can be incredibly complex, huge differential diagnosis, lots at stake.
That's right. So our mission today is a real deep dive. We want to get into the evidence-based management for hematuria in hospitalized patients.
Exactly. We're going beyond just defining it. We want to give you, the clinician listening, a really structured way to think about this. Classification, risk stratification, the workup, the management.
And the key goal, I think, is finding that balance. How do we avoid over-testing, the low-risk folks with benign causes?
While making absolutely sure we don't miss the serious stuff. Malignancies, progressive kidney disease.
That tension, right, between doing too much and doing too little. It's sort of the classic hospital medicine challenge.
For sure. And our approach today, we're pulling from the best sources.
Yep. We've synthesized guidelines from the American Urological Association, the AUA.
The American College of Radiology, ACR.
The American College of Physicians, ACP. And, of course, key studies from top journals. Think the New England Journal of Medicine.
And EJM.
And JMA. The idea is to move past just reflex ordering and get, well, more precise.
Okay, let's jump in. Section 1, classification. It sounds basic, but it's where everything starts.
It really is. Hematuria just means blood in the urine. Simple enough. But how we classify it right off the bat changes everything.
Because visibility equals urgency, basically.
Pretty much. First split. Is it gross or microscopic? Gross hematuria is what the patient sees. Red urine, pink, brown, sometimes even clots.
Obvious.
Then there's microscopic hematuria, or non-visible. You only find that under the microscope.
And the definition there is pretty standard.
Yeah, the AUA and others agree, is finding 3 or more red blood cells, RBCs, per high-power field. That's per HPF.
3 or more RBCs per HPF.
On a good sample, naturally.
Right.
Properly collected, spun down, looked at carefully.
Got it. And why does this gross versus microscopic thing matter so much right at the start? You mentioned urgency.
It's all about the pre-test probability of something serious, especially cancer.
Okay.
Gross hematuria. That's a major red flag. It signals a much, much higher risk of underlying pathology.
How high are we talking?
Well, the literature quotes malignancy risk, particularly bladder cancer, as high as 30, maybe even 40%.
30 to 40%. Wow.
Yeah. So you just can't manage that casually. It needs prompt, rapid investigation. Usually that means cystoscopy and imaging.
Okay, so gross hematuria, high alert. What about microscopic?
Microscopic hematuria carries a lower risk.
Yeah.
Definitely lower. But it's not zero.
Still needs attention.
It does. The risk is cited around maybe 2.6 to 4% for malignancy. Still significant enough that you can't ignore it if it's persistent and unexplained.
Right.
But the workup, the timing, how aggressive we are, that really depends on other risk factors, which we'll definitely get into.
Okay, so that's the first split. Visible versus non-visible. What's the next critical classification?
The next big one, and maybe the most important decision point early on for us as hospitalists, is figuring out the anatomical source.
Right. Is it the kidney itself, or is it the pipes?
Exactly. You framed it perfectly. Is the plumbing damaged, or is the filter failing? This split dictates who we call nephrology or urology.
So tell us about the filter problem first. Glomerular hematuria.
Right, glomerular or nephrogenic hematuria. This means the bleeding is coming from the kidney parenchyma itself. Specifically, there's damage to the glomerular capillary wall.
The filtering units.
The filtering units, exactly. This points towards primary kidney disease, and that means we need nephrology involved. The clues are often in the urine sediment itself.
Okay, we'll get to those clues. And the other side, the plumbing.
That's non-glomerular or urogenic hematuria. The bleeding originates anywhere below the glomeruli. So renal pelvis, ureters, bladder, prostate in men, urethra.
The collecting system and exit route.
Yep. And this is usually caused by structural things, stones, infections, tumors.
And this is urology's territory.
Squarely in urology's court. So figuring out which camp the patient likely falls into based on history, symptoms, and crucially, that urine microscopy that needs to happen early.
Makes sense. So let's move into that initial assessment. Patient comes in, maybe to the ED, maybe admitted directly with hematuria. What's step 1 before we even think about CT scanners?
Step 1 always is safety. Life threats. In the hospital setting, you've got to quickly identify anything immediately dangerous or reversible.
Like what?
Severe bleeding, obviously.
Yeah.
Hemodynamic instability. Is the patient obstructed? Acute urinary retention from clots, maybe. Sepsis from a bad UTI. Coagulopathy.
Okay.
So admission is definitely needed if someone's hemodynamically unstable, hypotensive, tachycardic.
If they're in clot retention.
Definitely. Acute renal failure, AKI.
Or septic.
Or septic. Fever, rigors. Stabilize first, diagnose second. That's the mantra.
Okay, patient's stable, or we've stabilized them. Now we need history and physical. What are we focusing on? This isn't just a routine H&P.
No, it's targeted. We're hunting for clues. First, the bleeding itself. When did it start? Is it constant, intermittent, and critically, are there clots?
Clots mean lower tract.
Strongly suggest lower tract, yeah. Usually bladder or prostate. Then associated symptoms. Flank pain. Could be a stone, pyelonephritis, burning with urination, dysuria, urgency, frequency, difficulty starting a stream, retention.
Makes sense.
Recent trauma, procedures, even vigorous exercise sometimes, and, absolutely critical, the medication list, especially anticoagulants, antiplatelets.
We'll circle back hard on that one, but first, you mentioned risk stratification earlier. This history needs to screen for malignancy risk factors, right?
Immediately. This is where we decide how aggressive the workup needs to be. We have a pretty clear checklist based on solid evidence linking these factors to urothelial cancer.
Okay, let's run through that checklist. What puts someone in the high-risk bucket?
Number 1, age. Usually the cutoff is over 35, but more guidelines now are leaning towards age greater than 40.
Age over 40.
Second, male sex. Men have a higher risk. Third, and this is a huge one, smoking history.
Past or current?
Both. Any history of smoking significantly bumps up the risk, especially for bladder cancer. It's the biggest modifiable risk factor.
Okay, age over 40, male, smoker. What else?
We need to ask about occupational exposures. Certain chemicals, dyes. Think industries like textile, rubber, leather manufacturing. Aromatic amines are the classic culprits. History of pelvic radiation. That increases risk. Certain chemo drugs like cyclophosphamide, same deal. And chronic situations like long-term indwelling catheters, chronic UTIs. These can sometimes lead to squamous cell changes.
So if any of those risk factors are present,
then the patient is considered high risk. And that's true whether they present with gross or microscopic hematuria. The presence of these factors mandates a more thorough, usually dual workup.
Got it. Now let's tackle that landmine, the anticoagulation trap. We see this constantly. Patients on Eliquis or Xarelto or warfarin, they have hematuria. Easy answer, it's the anticoagulant.
Right, and that is such a dangerous assumption. It's probably one of the most common high-stakes mistakes made.
So what's the evidence say?
The evidence is crystal clear. Being on anticoagulation or antiplatelet therapy does not mean you don't need a workup for hematuria, especially if the patient has those intrinsic risk factors we just discussed: age, smoking, male sex.
So the drug doesn't cause the hematuria, it just reveals it.
It unmasks it or amplifies it. Think about it. If there's a small tumor or maybe a stone that's causing microscopic bleeding you would normally notice.
Put them on an anticoagulant.
And suddenly, boom, gross hematuria. The underlying pathology was already there. The drug just made the bleeding significant enough to become apparent.
I've definitely heard colleagues say, well, the INR was high, or they just started the DOAC, let's just watch it. How do we push back against that?
You push back with the data. Studies like one in the Journal of Urology, I recall, show that the rate of finding malignancy in anticoagulated patients with hematuria was pretty much the same as the rate in high-risk patients not on anticoagulants.
So the baseline risk is the driver, not the drug.
Exactly. The patient's intrinsic risk profile dictates the workup, period. The anticoagulation status might affect how you manage the acute bleeding. Maybe you need to hold the drug or reverse it if it's severe.
But that's treatment, not diagnosis.
Precisely. That's a therapeutic decision. It doesn't change the diagnostic imperative. If they meet high-risk criteria, they need the workup, cystoscopy, and imaging, regardless of their coagulation status. We treat the bleed, yes, but we investigate the source.
Okay, message received. Avoid the anticoagulation trap. Now, initial labs at the bedside. What are the must-haves beyond a CBC?
The absolute cornerstone is the urine sample, urinalysis, and crucially, urine microscopy.
Why both?
Urinalysis confirms it's real hematuria, checks for infection markers like nitrites and leukocyte esterase, looks for protein, but the microscopy is where we look for those crucial morphological clues we talked about: dysmorphic cells, casts.
Got it. So high-quality UA and microscopy.
Yep. Then, besides the CBC to check for anemia, You need a renal function panel, BUN, creatinine, electrolytes.
To assess kidney function.
Right, and the coagulation profile, PT, APTT. Essential to know their clotting status up front.
PT, APT2. Okay.
And finally, if there's any suspicion of urinary retention or obstruction, maybe the patient can't void or has suprapubic pain, a quick bladder scan, or even better, a bedside POCUS.
Point of care ultrasound.
Yeah, POCUS.
Right.
Look at the bladder volume, glance at the kidneys for hydronephrosis. Quick, easy, high yield in that situation.
Okay, good initial set. Now let's dig deeper into the causes, the etiology. We keep coming back to glomerular versus non-glomerular. Let's really focus on the evidence that helps us differentiate. Starting with glomerular, the filter problem.
Right. So glomerular diseases mean the kidney itself is the primary site of injury. As hospitalists, we're not usually making the definitive diagnosis that often needs a biopsy, but we have to recognize the pattern.
To avoid sending them down the wrong pathway.
Exactly. Avoid that unnecessary radiation-heavy urology workup if the problem is actually medical, needing nephrology. What's the most common cause we see?
IgA nephropathy.
IgA nephropathy is definitely the most frequent worldwide, often presents with gross or microscopic hematuria. The classic story is synpharyngitic hematuria.
Meaning it happens right alongside or just after like a sore throat or cold.
Exactly. Gross hematuria pops up within maybe 24 to 48 hours of an upper respiratory infection. That close timing is key. It helps distinguish it from post-infectious glomerulonephritis, which usually has a longer delay, maybe weeks.
Okay, IgA. What else is on the glomerular list?
You can have thin basement membrane disease. That often just causes persistent, isolated microscopic hematuria, usually without much protein, often familial.
Less dramatic.
Less dramatic, usually benign prognosis. Then there's hereditary nephritis, like Alport syndrome, think family history, hearing loss, eye problems.
Yeah, the really serious ones.
Yeah, the ones we really worry about in the hospital are things like ANCA-associated vasculitis.
ANCA vasculitis.
Like granulomatosis with polyangiitis or microscopic polyangiitis,
Yes.
or lupus nephritis. These usually come with systemic symptoms, maybe rapidly worsening kidney function, significant proteinuria.
These sound like nephrology emergencies.
They can be. If you suspect these, you need urgent nephrology input, and you're sending off specialized labs like ANCA levels, complement levels, anti-dsDNA, etc.
So how do we actually prove the filter is the source? At the bedside or in the lab? You mentioned microscopy.
Microscopy is king here. It's the closest thing to a non-invasive biopsy for differentiating the source. We're looking for signs that the red blood cells got beat up, squeezing through damaged glomeruli.
Okay, what does that look like?
The main finding is dysmorphic RBCs. These are red cells that look weird, misshapen, irregular borders, maybe little blebs sticking out. They got physically damaged.
Just generally abnormal looking.
Yeah, but even more specific than just general dysmorphism is finding acanthocytes.
Acanthocytes. I've heard them called Mickey Mouse cells.
That's the classic description. They look like little rings with blebs sticking out like Mickey Mouse ears. Finding these is highly specific for glomerular bleeding.
How many do you need to see?
The threshold is pretty well defined. If more than 5% of the red cells you see are acanthocytes, that strongly points to a glomerular source.
Greater than 5% acanthocytes.
Okay. Seeing that can potentially save the patient a whole lot of unnecessary urologic testing.
That sounds great, but practically speaking, how often does the lab report give us that level of detail? A lot of places use automated readers now.
That is a huge practical challenge. You're right. Automated urinalysis systems are fast, but they often just flag abnormal RBC morphology or something generic. They can't reliably identify acanthocytes or quantify dysmorphism.
So what do we do then if we can't get that specific finding?
It's tough. Ideally, the institution has a process for getting a manual microscopy review by a trained technologist or pathologist when the source is unclear. If that's truly not available, well, then you have to rely on other, perhaps less specific clues.
Like proteinuria.
Proteinuria is a big one. Glomerular bleeding is often, though not always, accompanied by significant protein leak. So more than just trace protein on a dipstick, especially if it's in the nephrotic range, pushes you towards a glomerular cause.
Okay. And the other classic finding?
The other classic, absolutely pathognomonic finding is the red cell cast.
Pathognomonic, meaning if you see it, you know it's glomerular.
Absolutely. A red cell cast is basically a clump of red blood cells trapped inside a protein matrix that formed in the shape of the renal tubule. It's like a little mold of the tubule made of blood.
Proof the blood came from way up high in the nephron.
Exactly. It's 100% specific for glomerular bleeding. The problem is
They're hard to find.
very hard to find. They're fragile, they break down easily, especially if the urine is dilute or alkaline. So they are highly insensitive, meaning not seeing them doesn't rule out glomerular disease at all.
So high specificity, low sensitivity.
Right. But if you do see them, combined with dysmorphic cells and proteinuria, that's a slam dunk for calling nephrology.
Okay, that clarifies the glomerular picture. Now let's shift to the non-glomerular causes the plumbing problems. This seems like a broader category.
It is, because it covers everything from the kidneys collecting system down. Let's break it down by location. Upper tract first, kidneys and ureters.
What's common there?
By far the most common cause is nephrolithiasis, kidney stones.
Stones. Usually painful, right?
Often, yes, classic flank pain.
Mm-hmm.
But sometimes stones, especially small, non-obstructing ones, can just present with hematuria, microscopic or gross, without much pain.
Okay. What else in the upper tract?
Malignancy is the big worry. Renal cell carcinoma, RCC, in the kidney itself, or upper tract urothelial carcinoma, UTUC, in the renal pelvis or ureter. Also things like polycystic kidney disease, papillary necrosis, maybe related to diabetes or NSAID use.
Got it. Now moving down to the lower tract bladder, prostate, urethra.
This is where we find the single most common cause of hematuria overall.
Which is?
UTI, urinary tract infection.
Okay, so always rule out UTI first.
Always. Send the culture, look for pleuria, bacteria microscopy. But here's a critical point.
Yeah.
Even if a UTI is present, if the patient is high risk for malignancy, smoker over 40, etc., you can't just treat the UTI and stop.
Why not?
Because the infection might be secondary. Maybe there's a bladder tumor causing irritation or obstruction, making them prone to infection.
Right.
The UTI might just be masking the real problem.
Okay. So treat the infection, but still complete the malignancy workup if they're high risk.
Exactly. Other big lower tract causes, bladder cancer itself, of course.
Right.
Very common, especially in those high-risk groups.
And in older men.
Benign prostatic hyperplasia, BPH, extremely common cause of hematuria, often gross hematuria in older men. Those enlarged prostate glands have fragile surface blood vessels that can easily bleed.
Okay. So what does the microscopy look like for these non-glomerular causes? How does it differ from the glomerular picture?
It's usually the opposite. Instead of beat-up dysmorphic cells, you typically see uniform, normal-looking RBCs.
Feels healthy.
Yeah, they look like regular red blood cells, maintaining their nice biconcave disc shape because they haven't been forced through a damaged filter. They just leaked out from somewhere in the plumbing.
Makes sense. And no casts, presumably?
Right. No acanthocytes and definitely no red cell casts. You might see white blood cells if there's a UTI or crystals if there are stones, but the red cells themselves look normal.
Okay. And we should also remember those transient benign causes, right?
Absolutely. Before launching into a huge workup, especially for isolated microhematuria, always consider things like recent vigorous exercise, menstruation in women, recent bladder catheterization, or urologic procedure.
Things that explain it and will go away.
Exactly. If you suspect one of these, the right move is often just to repeat the urinalysis in a week or two after the potential cause has resolved. Don't jump straight to CT and cystoscopy.
Good point. Okay, let's transition to the diagnostic workup itself. We've stratified the risk. We've considered the source based on microscopy. Now, how do we choose the right tests? This feels like where the balance between finding cancer and causing harm really comes into play.
It absolutely is. And the guidelines are fairly clear, especially for the high-risk group.
Who are they again?
Age over 35 or 40. Gross hematuria or microhematuria with those key risk factors, smoking, occupational exposure, etc.
Okay, for that high-risk group, what's the recommended approach?
The standard recommendation is a dual approach. You need to evaluate both the lower tract and the upper tract.
Both? Can't skip one.
Can't skip one in a high-risk population. For the lower tract bladder and urethra, the gold standard is cystoscopy.
Direct visualization with a scope, why is that so crucial? Can't imaging see the bladder?
Imaging, even good CT imaging, struggles with certain bladder pathologies. It's particularly bad at picking up flat lesions, like carcinoma in situ, which is a high-grade, dangerous form of bladder cancer. It can also miss smaller papillary tumors sometimes.
So CT can miss bladder cancer?
It can. Cystoscopy allows direct visualization, biopsies if needed. It's simply the most sensitive way to rule out bladder cancer, which again is the most common cancer we find in hematuria workups. So, imaging does not replace cystoscopy for the lower tract in high-risk patients.
Okay, cystoscopy for the lower tract. What about the upper tract kidneys and ureters? This seems to be where the imaging choices get debated.
They do. The two main players are CT urography and renal bladder ultrasound.
Let's start with the top tier. CT urography. When is this the go-to?
CT urography is generally preferred for high-risk patients, especially those with gross hematuria. Its big advantage is its diagnostic power.
What does it show?
It gives incredibly detailed pictures of the kidneys, ureters, and bladder. It uses multiple phases, non-contrast, contrast-enhanced, nephrographic phase, and delayed excretory phase. This combination is excellent for finding kidney stones, renal masses, like RCC, and importantly, those upper tract urothelial cancers in the renal pelvis or ureters, which can be subtle. The sensitivity and specificity for upper tract malignancy are very high, often quoted above 90% sensitivity, near 99% specificity.
Sounds like the definitive test for the upper tract, but there are downsides.
Big downsides, especially for our hospitalized patients. First, cost. It's an expensive test. Second, radiation. It's a significant dose covering the whole abdomen and pelvis multiple times.
We don't want to irradiate people unnecessarily.
Definitely not. And the third major concern, particularly relevant in the hospital, is the need for intravenous contrast dye.
The contrast-induced nephropathy risk, CIN.
Exactly. CIN, or maybe more accurately now termed, contrast-associated acute kidney injury. Giving IV contrast, especially to patients who already have underlying kidney disease or are maybe borderline volume depleted or have diabetes, it carries a real risk of worsening their renal function.
And a lot of hospitalized patients do have AKI or chronic kidney disease.
Precisely. So for a patient admitted with, say, AKI and gross hematuria, ordering a full CT urography protocol might be contraindicated or at least require very careful consideration and hydration protocols. The risk-benefit calculation shifts.
So if a high-risk patient can't get contrast for CT urography due to kidney function, what are the alternatives? We still need to evaluate the upper tract.
It's a compromise. You lose diagnostic yield, but you protect the kidneys. One option is a non-contrast CT of the abdomen and pelvis.
What does that show?
Excellent for stones, pretty good for solid renal masses, but it's poor for detecting urothelial cancers in the collecting system because those often only show up as filling defects on the delayed contrast phase.
Okay. Other options?
If the suspicion for an upper tract urothelial cancer is really high, based on risk factors or maybe cytology, urology might opt for a retrograde pyelogram.
What's that?
During the cystoscopy, they thread a small catheter up the ureter and inject contrast directly into the collecting system from below, then take x-rays. It images the upper tract lining well without needing IV contrast, but it's invasive.
Okay, so CT urography is the best look, but with risks. What about the other main option, ultrasound? Renal and bladder ultrasound.
Ultrasound is the recommended first-line imaging for patients who are lower risk. So typically younger patients with microscopic hematuria and no major malignancy risk factors.
Why ultrasound for them?
The benefits are huge in that group. It's completely safe, no radiation, no contrast dye. It's much cheaper. It's widely available, often doable right at the bedside with POCUS. It's great for looking at kidney size, checking for hydronephrosis, detecting larger renal masses or cysts, and looking for bladder abnormalities like wall thickening or large masses.
Sounds like a good screening tool for low-risk folks. What's the catch?
The catch is sensitivity. Ultrasound is just not as good as CT for seeing small things. It can miss small renal masses, especially those under a centimeter or so. And it's particularly limited in visualizing the ureters and detecting non-obstructing upper tract urothelial tumors.
So using ultrasound in a high-risk patient might lead to a missed cancer.
That's the concern. It could lead to a false negative. So the strategy really has to be risk-adapted. Ultrasound is great value for low to intermediate risk microhematuria. CT urography, or a contrast-sparing alternative if needed, is generally required for the high-risk patients.
This really drives home the point about avoiding reflexive universal testing. Just ordering CT urography on everyone with hematuria sounds thorough, but
it's not good medicine, globally speaking. Studies have looked at this cost-effectiveness. Uniform CT for everyone finds only a tiny bit more pathology compared to a risk-stratified approach, but at a massive increase in cost, radiation exposure, and potential contrast complications. It represents low-value care for many patients.
Makes sense. One other test people sometimes mention is urine cytology, sending urine off to look for cancer cells.
Yeah, voided urine cytology. The general consensus now is that it's not a good first-line screening tool for hematuria.
Why not?
It's quite specific, meaning if it's positive for high-grade cancer cells, that's a reliable finding.
Yeah.
But its overall sensitivity is poor. It misses a lot of cancers, especially low-grade bladder tumors. So a negative cytology doesn't rule much out. It has a role in surveillance for known bladder cancer, perhaps, but not really in the initial diagnostic workup of hematuria.
Okay, good to clarify. Let's shift gears to acute management. Patients in the hospital, maybe they came in unstable or developed a problem. What are the urgent priorities?
Right, back to the acute setting. Priority number one, as always, is hemodynamic stability if they're bleeding heavily. 4V fluids, maybe blood transfusion if the hemoglobin is dropping fast, or they're symptomatic from anemia.
Okay, stop the bleeding or replace the losses. What else is an emergency?
Clot retention. This is a true urologic emergency.
Because it's painful and causes kidney injury.
Excruciatingly painful. And yes, if clots fill the bladder completely, urine backs up, potentially causing bilateral hydronephrosis and rapid acute kidney injury.
Yeah.
It needs immediate action.
What's the action?
Get a catheter in.
Yeah.
Usually not a standard Foley, though. You need a large bore, often a 22 or 24 French, three-way catheter.
Three-way for irrigation.
Exactly.
Right.
One port inflates the balloon, one drains urine clots, and the third allows for continuous bladder irrigation, or CDI. You run sterile saline in, it helps break up clots, and then it drains out.
Does that always work?
Often it does, especially with some vigorous manual irrigation. First, using a large syringe to forcefully instill and withdraw saline to dislodge big clots. But if you can't get the catheter in, or if CBI isn't clearing the obstruction and the patient remains unable to void,
then what?
then you need urgent urology consultation. They may need to come and evacuate the clot's bedside with specialized equipment, or sometimes even take the patient to the operating room for a cystoscopy and clot evacuation under anesthesia. Cannot delay that.
Okay, clot retention emergency urology consult. What if infection is the driver? Confirmed or suspected UTI causing the hematuria?
If a UTI is confirmed or strongly suspected based on symptoms, urinalysis showing pyuria, maybe fever, then you need to start empiric antibiotics right away.
Don't wait for cultures.
Don't wait. Get the urine culture, get blood cultures if they seem septic, but then start broad-spectrum antibiotics tailored to likely pathogens and local resistance patterns. Treat the potential sepsis promptly. You can always adjust the antibiotics later when sensitivities come back.
Makes sense. So let's crystallize the absolute red flags. The situations where a patient with hematuria needs immediate admission or an urgent specialist consult, no question.
Okay, the key red flags are: 1, definitely clot retention or any sign of acute urinary obstruction leading to AKI.
Got it.
2, hemodynamic instability, tachycardia, hypotension, signs of shock, or evidence of really brisk, ongoing bleeding like a rapidly falling hemoglobin. 3, acute renal failure, AKI, where the cause isn't immediately clear, especially if there are features suggesting something rapidly progressive like glomerulonephritis or vasculitis. 4, obvious sepsis or systemic infection, high fever, chills, rigors, altered mental status maybe. And 5, a severe or unexplained coagulopathy or bleeding issue that needs urgent reversal or management beyond just holding their usual anticoagulant dose.
Okay, those are clear triggers for urgent action. This flows right into specialty triage. When do we call urology and when do we call nephrology? This goes back to that core distinction.
It absolutely does. You call urology for the structural problems, the plumbing issues. Definitely for all cases of gross hematuria, period.
Yeah.
Doesn't matter the risk factors initially, gross hematuria needs urologic evaluation.
Okay. All gross hematuria urology.
Also, for high-risk microscopic hematuria, remember, age over 40, smoker, or maybe a very high number of RBCs, like over 10 per HbF consistently. Any suspicion of malignancy based on imaging or risk factors. Certainly for obstruction or clot retention. Basically, if you suspect a stone, tumor, BPH causing trouble or need clot evacuation, it's urology.
Got it. Urology, plumbing, structure, obstruction, gross bleeding, high-risk micro. When do we call nephrology?
You call nephrology when you suspect the filter is the problem, primary renal disease.
And the clues for that are?
The clues are those microscopy findings. Dysmorphic RBCs, especially acanthocytes, red cell casts, if you're lucky enough to see them. Significant proteinuria, particularly if it's nephrotic range, like grams of protein. Or if the hematuria is occurring in the context of new or rapidly worsening kidney function without another clear cause.
So nephrology, filter problem, dysmorphic cells, casts, heavy proteinuria, unexplained AKI with hematuria.
Exactly. They'll take over the workup for things like IgA nephropathy, vasculitis, lupus nephritis, etc.
Is there ever a role for hematology consultation?
Yes, occasionally. You'd consider hematology if the bleeding seems way out of proportion, or if the patient has a really puzzling coagulopathy. Maybe their PT or APTT is abnormal, but it's not explained by their known meds or liver disease. Or if they have other signs of a systemic bleeding disorder, like bruising or petechia.
Okay, so summarizing the overall picture, most hematuria is benign, right?
Thankfully, yes. Most cases, especially microscopic hematuria in lower-risk individuals, turn out to be caused by benign things like UTIs, BPH, stones, or sometimes nothing specific is found and it resolves. The prognosis is generally good once the cause is identified and treated.
But the key is not missing the bad actors.
That's the whole point of this structured approach. Better outcomes depend on prompt, risk-adapted management. We have to use the evidence, the clinical risk factors, the microscopy, to guide our intensity of investigation. Find the cancers and other serious conditions quickly in those who are high risk, while protecting the low-risk majority from unnecessary tests, costs, and harms. That's high-value hospital medicine.
Excellent summary. Okay, let's try to synthesize this deep dive into a clear pathway.
Sounds good.
So it starts with defining the hematuria. Is it gross or microscopic? That sets the initial level of concern.
Right. Then immediately, you apply the risk stratification. Age, smoking history, male sex, exposures. Does this patient fall into a high-risk category for malignancy?
Based on that risk, and crucially on the urine microscopy findings looking for dysmorphic RBCs, acanthocytes, red cell casts.
You make that pivotal glomerular versus non-glomerular split. Is it likely a filter problem needing nephrology or a plumbing problem needing urology?
That split then guides the next steps. For suspected non-glomerular high-risk cases, it's usually that dual approach, cystoscopy for the lower tract.
And targeted imaging for the upper tract. Typically CT urography if they're high risk and can tolerate contrast.
Versus renal ultrasound if they're lower intermediate risk, prioritizing safety and value.
Exactly. And throughout this, we're constantly watching for those acute red flags: clot retention, instability, sepsis, AKI requiring immediate management and stabilization.
And finally, ensuring the right specialty referral happens promptly based on all that information.
That's the framework. The core takeaway really is, this requires structure, an evidence-based algorithm that uses specific clinical and lab findings to determine risk. We must expedite care for the high-risk patients while consciously avoiding the harms of over-testing in lower-risk individuals.
That structured thinking is absolutely key for managing such a common yet complex presentation.
Definitely. Now, before we finish, let me leave you with a final thought, something to sort of mull over.
Okay, hit us with it.
We've spent a lot of time emphasizing risk stratification as the gold standard for high-value care. Use CT urography, with its costs and harms, only for the clearly high-risk patients. But we all know clinical practice isn't always that clean, right?
True. There are gray areas.
Exactly. So how should you, the clinician on the ground, handle that pressure? And sometimes it is pressure, maybe subtle, maybe overt, to just order the big gun, the CT urography, for that intermediate risk patient. Maybe the ultrasound is a bit fuzzy, maybe the clinical picture is just ambiguous. The guidelines might lean towards no CT, but defensive medicine or maybe specialist preference pushes towards, yes, get the full picture.
That's a real-world dilemma.
It is. How do you navigate that tension between adhering strictly to the evidence to minimize harm and cost for the population versus the desire for diagnostic certainty in that individual patient sitting in front of you, especially when things aren't perfectly clear-cut? It takes more than just knowing the guidelines. It takes some clinical courage and good communication, too. Something to think about.